coming from a very, very different background, so it's very difficult to make a presentation that everybody will understand equally. So please stop me wherever you cannot follow and feel free to ask me anything. This one? So yesterday, Dr. Devdeep and Dr. Deepak Mishra gave you an idea about what a pathology lab looks like. And there are various components. So there is histopathology, there is hematology, there is molecular pathology, cytogenetics. I am a histopathologist, so I will be concentrating most of this lecture on how computational science or artificial intelligence and machine learning plays a role in making pathology more advanced, getting to a better diagnosis to come to precision medicine, which is what Sanjay gave you an overview about. So pathologists did most of their work on microscopes till the digital scanner came into the picture. So are you familiar with the scanner? Do you have some computation background, most of you? Yeah? So this is where he told you about how the lab works. When he sends a patient for a biopsy, that tissue is taken and processed and we make glass slides. We look at the cells through the glass slide and make a diagnosis. So what digital pathology is done now, instead of looking at the glass slides through the microscope, we scan them and we look at it through the computer, which helps us pick up the details better in a more precise manner. That is the basis of digital pathology, and it's thought to be the third revolution in pathology. It's coming in a big way. We are one of the few centers to start it in India. We are not reporting on digital pathology yet because that's another whole different ballgame. But it's come in a big way into research. And we are doing that at Tata Medical Center. We have a Leica microscope-based scanner. So in the previous slide, I showed you these were one of the initial digital scanners which are microscope-based, and then this is moving on to high-throughput scanners. And there are hospitals in the US where pathologists don't even have to come to work every day for a 9-to-5 job. They can sit at home and report. All their slides go into the scanner, and these are very fast. They can scan a histopathology slide in 10 seconds, 15 seconds. So their entire workload is digitized. In India, there are a few labs which have started doing that, but it's still a very new area in the world of pathology in India. So if you're familiar with pathology, it's interesting to know that the first revolution in pathology which changed the way we practice medicine was when immunohistochemistry came into the picture. That was way back in the 1980s. In India, I think it came in more in the 90s. Then in 2010, next generation sequencing, molecular pathology and NGS, that is what, it became very cheap, it became easily available to diagnostic pathology, and it has really transformed the way we treat patients, the way we diagnose patients, the way we classify tumors these days. We can do all of that because of NGS, and now digital pathology is changing the science completely. So what is digital pathology and what is computational pathology? Can anybody tell me? What is the difference? So just scanning histopathology slides and reporting on them, which is what we've been doing for decades now. The scanners have come into the picture in the early 2000s, and we were using it for education, we were using it for morphometry, we were looking at cells in greater details, and using computer techniques to measure nuclear size. These are very preliminary computational techniques which we were using for research, and basically it was more for education and research. This is known as whole slide imaging and digital pathology, and it didn't really take off. It's been there for decades, but it was expensive, the pathologists still had to come to work, so it wasn't making a big difference from what the microscope was doing for us. But then computational pathology came into the picture. We got better at computing. The data scientists got better, the machines got better, the coding, the softwares got better. that is what has revolutionized, and this is why the whole world is now talking about artificial intelligence, machine learning, and computational pathology. So the big difference here in the world of pathology has been made by computation, which is why we thought of doing this course here, and which is why we as doctors need your help. So just looking at scanned images wasn't taking us far, but with working with data scientists, we can look at details which is not possible by the human eye to do, looking at the image through the microscope or just on the slide. So I am not going to be talking about the technical details of artificial intelligence and machine learning. Scott Doyle is the data scientist, and you'll be doing lectures next week, and he will get into the technical details. I think some of you must have seen Dr. Debdut's lectures also online, so he's the big expert on machine learning and deep learning. So I'll not get into the technical details, but just to give a basic overview of people here who are unfamiliar with these terms. So what we were earlier doing is just doing morphometry on the digitized images. But with computation, we are using algorithms where we are not telling the computer what to do. The computer is learning and working like a human and giving you the output. When you are giving the computer the problem, he wants to know what is a better tumor. He was talking about precision medicine. He has 10 breast cancer patients. He wants me to tell him, and they all look like breast cancer is graded. So I call, and typed. So a type of breast cancer is invasive ductal carcinoma. And then I can give him a grade. I call it grade 3. If I give him 10 invasive ductal carcinomas grade 3, all 10 of them can be treated similarly by him because he has no other information from pathology, but they will not behave similarly, which is what he was trying to say with precision medicine. But the big data and deep learning, we are now thinking that the computer can tell us, even in those 10 cases, that there is a difference, and this case will behave worse than that case. That is knowledge beyond what is currently available to us in pathology. This is what machine learning or computational pathology is going to take us, and we are seeing results. There are studies which have been done, and I'll show you some examples, and that is why we are so interested in this subject. I will also, do you know can somebody tell me what are these things? Supervised learning, unsupervised learning. Are you aware? Anybody? I think somebody was back there. Yes, tell me. Right. Yeah, we will not just be giving a data set, we'll be giving an annotated labeled data set. We'll give them images of 10 tumors, and we'll say this is 5 bad tumors, which is 5 good tumors. Now the machine will learn that, and then we give them a second test data set, and based on the information we've given in the initial annotated data, the machine will be able to solve the next and give you the answer for the next test cases. So in unsupervised learning, the machine itself will pick up from the patterns and be able to tell you what is a good tumor and what is a bad tumor. So you have to know what kind of data you have and what is your problem, what is the problem that you're trying to solve. Based on that, you use different algorithms, and these are different names of the algorithms which people have used, and Scott will elaborate further on how do we solve when we get a problem, what do we use, and how do we write our algorithms to work on, get to our answer. To give a layman's example, this is what I understand. So Facebook clustering is a type of unsupervised learning. You are not telling, Google Images has tons of images, you are not saying that this is you, but it picks up random images from and asks you to tag yourself, right? So how is it doing that? That is unsupervised learning. It's not been annotated, but from familiarity of features, it is picking up that this is likely to be you and not somebody else, and it will give you ask you to tag. And when you tag, you are giving reinforced feedback information back to that software. That what it has, the image it has picked up from Facebook and is showing as you are correctly identifying as you, so you are giving a positive feedback loop. So it improves its algorithm based on that positive reinforcing feedback. So these are examples of how these kind of machine learning algorithms, it's the same thing, whatever is being used in digital imaging computation is being used in Google all the time. It's been, the same thing is being used in pathology to make diagnosis better. And this is the new thing in computational pathology, that is deep learning. It is thought to be better than machine learning. What you need is better computing machines for this, and you need a lot of data. You need big data to get into deep learning. Deep learning is too complex for me to explain on this platform, but what it uses is convolution and neural networks. It's a kind of computation. I'm not going to get into explaining that to you, but it helps in giving results, like I explained about, I can't see on the slide which is a poor prognosis tumor, which is a good prognosis tumor, but when you give the computer thousands and thousands of breast cancer images, it can, based on, and you give the results that this person failed or this person is surviving. Based on that information, the computer can pick up features in morphometry which are not visible to the pathologist's eye. So that is what is deep learning. And that is what is we are expecting will change the way we diagnose cases in future using machine learning. This is a machine learning project blueprint. This, again, Scott will elaborate on this, but my role here is to define the problem. Tell you, why do we need computational pathology? Why are pathologists interested in this field? Can we automate diagnosis in pathology? Is computational pathology going to replace our jobs? So what are the challenges in pathology currently that we face in the hospitals? When we diagnose, there is a lot of inter and intra-observer variation. I think all of you would have some relatives or another who've had a report from, knows a patient, they've had a report from one lab, they've gone to another lab and got a different report. So this is a common thing in histopathology because it's a very subjective science. We do grade our tumors, we do scoring, but this grading is also, the criteria are not very well defined. It's not in mathematics like 2 plus 2 is always 4. With bringing in computation, we expect that we will make our reporting more objective, more precise, that every time we see the same breast cancer biopsy slide, we will give the same grade repeatedly. We will not call it grade 2 once or grade 4 another time. He gave you an example of ERPR scoring. Now scoring is supposed to be absolutely precise, but in India we've had 10 labs giving a 10 different kind of, giving a very variable percentage difference of ER positive cases between one lab and another. So this is where subjectivity of reporting, subjectivity of the way we score by our conventional system of looking at slides through the microscope plays a big difference in the way we are treating patients. And using computational techniques, the idea is that we will get more accurate for better treatment. I gave you an example of deep learning, that there are certain features in the slide. The features are there. They're there in the molecular level, they're there in the cellular level, but they're not visible to us because we are seeing the slide through the microscope only in a few objectives, and the human brain can only concentrate on a few features at a time. When we are looking through the slide, we see what is the cell feature like, what is the nucleus size like. There's something called lymphovascular invasion. The tumor cells, they spread through the blood vessels into the other parts of the body. There are perineural invasion is another feature. The tumor cells spread along the nerves to the other part of the body. So these are different prognostic features which we look for in a tumor when we are reporting, when the pathologist is reporting. And these prognostic features make a big difference in the treatment outcome, in the prognosis of the patient, and in the way the doctor is deciding what treatment to give the patient. All these features make a difference. So, but with humans, it's very difficult to accurately report all these different criteria. And we feel the machine can probably do this better than we can. And also the last point, manpower costs are not cheap. For a histopathologist or a pathologist or a doctor, to gain the expertise or the level of confidence to report all these details that you need to very accurately, very precisely, take years. And they don't come cheap, and it takes a lot of time also. And we know that many hospitals are short-staffed, especially the peripheral regions of the country. They don't have access to good doctors. So if we can do machine-based diagnosis or reporting in these areas, that can make a big difference, and that can save costs. So these are the challenges that we face currently. Giving you examples, these are some papers highlighting Ki67 is something he told you about. It's a score, it's an immunohistochemistry and a score we do in breast cancer patients and which guides treatment. There's a huge inter-observer variability, not just in our country but world over. This is a Danish study reporting it. And this international multi-center study has shown that automated techniques of scoring Ki67 using digitally scanned images and using computer-based scoring is a lot more accurate than the gold standard is still the experts doing histopathology reporting on glass slides, but inter-observer variability is lower in the automated techniques. This is an example of a low-grade urothelial carcinoma and a high-grade urothelial carcinoma. When I give a report on a biopsy, that patient saves his bladder. Urothelial carcinoma is bladder carcinoma. Bladder is part of the urothelial tract which produces, stores urine. So that patient saves his bladder and is only given drugs. And with this high-grade urothelial carcinoma, if it's muscle invasive, this person will lose his bladder. So can you tell the difference between the two? There are some black dots which are nuclei in pink stroma. So it's very subjective, and making a wrong diagnosis can make a killer. So this is a challenge in computational pathology, that can we define our criteria better and get the machines to be more accurate in making this diagnosis repeatedly so that we don't make mistakes. And then the cost cutting. He told you about radiation and chemotherapy in breast cancer. So there's something called neoadjuvant chemoradiation. That is, before the patient is operated, they are given radiation and chemotherapy, and then the patient, if the patient has breast cancer, then the breast is operated. This improves survival. This is the common treatment protocol that is followed for breast cancer patients. But what happens to us pathologists is we get a specimen which has been treated, so there is very little tumor left in the specimen of breast. And we have to put hundreds of slides, practically sometimes the entire breast, we get 100 or 200 slides in a case to find whether there is any residual tumor. Because if we don't document that accurately, the next treatment, whether the patient will continue to get chemotherapy, is decided by my pathology report. It's very tedious, it's a lot of hard work, and we can miss a tiny focus of tumor if we are not very diligent and careful. So these are areas where there is no fatigue in machines, and if we can digitize these and use computational techniques to help us diagnose, then we will save money and get accurate diagnosis. Yesterday, Dr. Devdeep showed you an example of sentinel lymph node biopsy. So the tumor goes to the lymph nodes, and we can miss a tiny focus on manual screening, where studies have shown that computational techniques do that, are superior to human screening for sentinel lymph node reporting. So these are the artificial advantages of computational pathology. Machines can learn faster than training a good histopathologist can take years. They don't fatigue. Okay, their memory capacity doesn't shrink with age. And they don't get distracted, so the repeatedly you get precision reporting from them, and the intra-observer variability is also lower. And so these are the why we are interested in changing over to computational pathology. None of us want to lose our jobs, but which actually in pathologists there is a lot of resistance to take up, to venture into computational pathology. But the important thing is it can do the stuff better for us and cheaper for us. So, and there are some difficult things to do like scoring, like mitosis counting, which are very tedious. So, if we can at least delegate some of our work to the machines, like the radiologists have and like in many other situations people have, that would make a big difference, and that is where the science is totally moving towards. Not really, not really, and I will tell you why. You will still, so there are images available, and you can all start computational pathology learning machine learning algorithms at home, but you will still need our help to validate your, is that correct, or is the Facebook will still pull out some wrong faces and tag them as you. So you still need that human interaction, and we can all help each other to make our lives better. When the science is there and it can do it better for you, for better patient care, we need to move in this direction. So to start in a lab, this is what we need. We need the hardware, which is the scanning system. We need good machines. If we are planning to do deep learning, we need GPUs, workflow engines, and high-speed networks. And we need to have a data scientist on our team who will know these programming languages to do the coding for us. But commercially available softwares are pretty common these days. And this is actually a big series of images from the chameleon data set by Jeroen van der Laak from Radboud University, and we are interacting with him for a few studies with our lab. So you can have access to online images, or if you are interacting with a lab like ours or some other hospital, you get access to images. Most of the digital hardware companies, scanners like I said, have been here for years now, decades now, have moved on to developing commercial softwares which help us do computational pathology, because they know that is where the market is, that is where the money is, and that is where the interest of pathologists also is, which is why it is coming in a big way. This is from Leica. It has the IHC scoring algorithm, there are immunofluorescence scoring algorithms, and there are some pattern recognition algorithms which we can use to make reporting easier. We in our lab use QUPath. In fact, it's like a drag and drop scoring algorithm. It will count your nuclear score. This is, I think, Ki67. It will identify membrane score. When you immunohistochemistry, when you do it, either stains the nucleus or the cytoplasm or the cell membrane. And depending on what IHC you're using, you have to score it. So this works better than the paid software that we have bought from Leica. We have a Leica scanner. So this is a very common and a very good software. If you want to play, it's freely available. You can download it. You can download some images from the net, and you can play like a. So we have used this to do a Ki67 scoring study in our lab, which Dr. Sanjay mentioned. And the gastrointestinal tract neuroendocrine carcinomas is another area where Ki67 scoring has to be done. And the cutoffs are as fine as, we have to say whether a cell has less than 2% or more than 2%, less than 19% or more than 20%. And the treatment is very different based on these cutoffs. And we are expected, the current recommendation is we have to count 500 cells on this to give the ideal score. Now nobody wants that job. Anybody who gets a GI neuroendocrine carcinoma wants to give it to the colleague because it's very tedious to do, and it's a big headache because you got a phone call in the middle of your 250th cell, you start all the way back from start again, or you've sneezed, you've lost which cell you were counting your thing for. So if the machine can do that, I'd want that. I won't lose my job if the machine is doing that instead of me, and I'd want that. So that is where computational techniques are helping us. So we are doing actually a validation study now to see whether the computational, the problem with the machine reading this is there are tumor cells and there are lymphocytes. Now the lymphocytes can also pick up brown stain because what Ki67 does is it highlights mitosis. Now the tumor cells are also having mitosis, the lymphocytes, inflammatory cells, macrophages, these are also having. So the human brain can tell that this is a blood vessel cell, or this is a tumor cell, or this is an inflammatory cell. The computer makes mistakes. So that is why you have to validate your algorithm. Just having an algorithm is not an answer. And that validation is the most challenging part of computational pathology, which is why it's not there yet, which is why there has to be a close interaction with the pathologist to fine-tune your algorithms. So we are trying to see whether the commercial algorithm software we have, whether they can do a better scoring than the pathologist is. This is another study that we are doing, which is the immune scoring of tumor microenvironment. Oral cancers, squamous carcinomas have a, so if you can, I don't know, make out anything on that slide, the top part is the epithelium of the oral mucosa, and the tumor cells are going into the stroma. In the stroma, there is a dense lymphoid background. There's a lot of lymphocytes. Now this background is very different in different patients, and currently in our understanding, we are realizing patients with dense lymphoid background do better than the patients without, and they can actually get a different targeted treatment. Now, looking at the lymphocytes, it's very difficult for us with the human eye to give a score of how many lymphocytes, B cells and T cells there are. We can only do this kind of scoring. The green is these different, you can't understand the different colors. This is actually an immunofluorescence kind of stating, whereas 7 different antibodies have been used against 7 different kinds of inflammatory cells, and we have come out with an immune score. Based on the immune score, the patient's prognosis is going to be different. That is the hypothesis, and that is what our study has also shown. And we have used computational techniques to get this score. This is still research. We are expecting that this will come into routine diagnostics soon. With Dr. Brandwein, I have a collaborative study looking at the worst pattern of invasion in squamous carcinomas. Again, these are, and tumor budding. Tumor budding is the tumor when it invades into the stroma, it sometimes in some patients it forms little tiny single cells or nests of cells, and that is a poor prognostic factor. Again, counting tumor buds is very tedious and difficult for humans, pathologists to do, and when you have 100 cases to report, you can't really sit and count one case, for it will take us 1 hour or to count the number of buds in a single case. So in a day-to-day practice, we cannot do that. It's only possible if we can automate these kind of steps in routine diagnostics. So that is a study that we are trying to do. And this is a study I've done with Jason Vanderlack of Radboud University. Prostate cancer is graded morphologically, looking at the pathology slide, and again treatment is different for the different grades. There are 5 grades in Gleason, 5 types of Gleason pattern, and depending on the grade, the treatment is different. Now looking at the images, I'm sure this will look very similar. This is pattern 3, and this is pattern 4, and this is pattern 5. It's very difficult for even a pathologist after years to very conclusively differentiate between pattern 3 and 4 and 5. It takes years to train to do that accurately. So they have developed an algorithm which will do that for you. So on this slide is the biopsy, the HNE, hematoxylin and eosin stained biopsy slide, and on that side, the yellow part is what the computer has highlighted as a pattern 4 area. This is a higher power of the same. So we were given 160 biopsies to score, and the machine score was also given on the side, and we were asked to evaluate whether the machine score was correct or wrong, and whether that was helping us in our reporting. So this is another biopsy where the red part is pattern 5. In the middle, you'll have to take my word for it. In H&E, there was a little bit of pattern 5, and the remaining top part and bottom part were pattern 4, which the computer AI system identified. This is a pattern 4 H&E tumor, and the computer correctly identified. This looks very similar to the prior one, but I can tell the circled area is pattern 5 and the remaining part is pattern 4. The circled part is more in sheets, like that in the corner. This part is more similar to that corner area, which is pattern 5, and this area is pattern 4. The computer unfortunately wrongly identified the 5 part as also pattern 4, but the small area of 5 it picked up correctly, but the large area of 5 it picked up wrongly. So AI is good, but it wasn't 100%. We have written up this paper, and it's been sent to Nature Communications for, so the result, that the final outcome was that after AI feedback, the agreement of the panel of, with the panel of experts, around 14 observers had graded these biopsies, and the inter-observer variability improved from 0.79, which is actually pretty good, to 0.87. So AI is unlikely to replace pathologists for Gleason scoring, but it can really make the pathologist's job much faster. When you can see that image where the computer is already recognizing and giving you a score, your job is done at half the time, and you can go and concentrate on those areas and just check whether the computer has done it correctly or not. Coming to the limitations, why is AI totally not there yet? Because the criteria in pathology is still very subjective, and it's not well defined. It's not, and diagnosis in cancer is not always binary. Cancer positive, cancer negative. That answers some of your queries, but not all real life patient cases. Sometimes there are 2 tumors. Sometimes there is an inflammatory pathology, there is cancer and there is non-cancer, 2 pathologies in the same biopsy. So it's a complex area. We are getting better every day, but it's not totally there yet, and it's for scoring immunohistochemistry, for tumor bud counting, for certain things, it's we have really fine-tuned our algorithms, but it's still a long learning curve. And also this DICOM, it exists for digital images, which is why exists for radiology images, which is why computational techniques in radiology is a lot more advanced than in histopathology. In histopathology, it's a very evolving science. It's a very so we don't have DICOM. When we scan our images in different scanners, all the information is not freely shared by to other vendors. When you're using open source algorithms, you may not get all the information, which is limiting for us right now. This is showing the rise of interest in artificial intelligence. You can see here in 2000, this is the number of publications in computational pathology, and it has really boomed over the last couple of years. So not time yet for us to throw our microscopes away, but we may be there soon. Thank you.